made a handout of this. It is going to come up on canvas. But you must have seen the title of this week is acute diarrhea. We will bring this structure to those two words, diarrhea and dehydration, and keep going with it. Try and explain some clinical terms as we go along. There's some science that I'm talking about. Hopefully the videos will work and you'll be able to appreciate those clinical science. And then also, if your patient has come to you with a problem, you're going to discuss some principles of management. This is your next summary of the learning outcome, as you see on the slide. Okay, it summarizes all the key things that we talked about in the last slide. So, as you read the code, if a patient doesn't give you a good history, and as a clinician, you cannot take a good history, we both are in trouble. Okay? And you probably will be tested in the OSCEs at the end of this year to take this history in perhaps 6.5 minutes. So to set a foundation of this building, we need a good, solid foundation. Can I just urge you all, if you're going to become that good clinician of the future, you need to learn how to take a history. So it might be new, the terms will be new, but the aim of this is to understand the structure. Nobody is expecting you to memorize this structure at the end of this week. The more you practice it with your patients, the more you go for learning opportunities in clinical settings, this will become clearer. Okay? So, as the word says, history, okay? Somebody said it is story. His and hers story. What is the story of your patient? How are we going to take this? The next few slides will be new terms. I'm going to slow you down. I want you to raise your hand if you don't understand anything. I quite like dialogue, and I know there are a lot of students in the room, but we should still be able to have a dialogue. So if you're not sure of what I've said, and that's been confusing, there will be time to ask questions midway through the lecture. The first thing, if you were to take a history today, the day today, what day?
5th of September.
5th of September. Yeah, okay, good. I'll write the time and date. Why do I need to do that? Why do I need to record that in my notes? Yeah, good, very good, well done. It is a medical legal requirement. Okay, so if you ever start with taking a history without a date set in time, there's no chronology. Okay, so it's a medical legal requirement that you start with that. I have come to you this morning with diarrhea. Okay, I don't have that, I'm just saying. So that's my presenting complaint. I've come to you as a doctor saying, I've got a problem. That is my own words. So you will record the presenting complaint in my own words. You will not change it. You will not add it as you like or change it. Happy with that? So that's my presenting complaint. By the end of this lecture, you may have a headache. That's your presenting complaint. Yeah, okay. But patients, do they have only one problem? Do they have only one presenting complaint? Often not. So whatever they come in with, presenting complaints become 1, 2, 3. That's how you record. Now they've told you the presenting complaint. I've told you about diarrhea this morning. You will ask me some further questions. Okay. When I give you a symptom, you need to go further and dig in and find out. So there's some direct questions. I need 4 volunteers for this. I want you all to stand up. Nothing to do, it's not me. You don't have any questions to answer. Thank you. Please stand up. Please stand up. Please stand up. Thank you. One more. Thank you. Okay, right. 4 colleagues here. So, I'm going to give you a new name this morning. Okay? Your name is going to be Onset. Say it again. Onset. Thank you. Your name is going to be Duration. Thank you. Your name is going to be Character. Character. Your name is going to be Severity. Severity. Right. So these are your 4 probes. Let's start again. Okay? Onset. Duration. Character. Severity. I came to you this morning with diarrhea. So what should be a direct question for me? Onset. Very good. How did it start? What did I eat? Did I go on a nightclub? How did it start? Was it dry? Did I Okay. Duration. How long has it been going on? Has it been going on in a day, 2 days, 2 months, 3 months? Did you get the structure? Onset, duration, character. Is it running? Is it smelling? This is my job, okay? As a pediatrician, I look after children with tummy problems. So if you come to my clinic, all I do is talk about food. Yeah, so it's an interesting combination. So character, okay? Is it painful? Is it hard? These questions will come to you, but I'm just trying to make a point here of how you approach, okay? Last one of the probes. Severity. How bad is it? How bad is my symptom? How bad is it in terms of my activities? What have we been able to do? So one last time. Onset. Duration. Character. Severity. Thank you, folks. Please take a seat. Okay, so for the remaining other I need to do the stage. Because we're going to drill this principle of how to approach a symptom. I use the word there, symptom. Symptom is what I say as a patient. Sign is what you pick up as a doctor. Make sense? Symptom, sign. All right. So, what's the functional inquiry? I'm making more detailed further questions. Is it just the diarrhea, or do I have anything else? There's a lot more to cover in the history of present complaint. ICM will go through some of it as well, but this is to just give you a brief outline. Past medical history. Have I been well before? Have I had diarrhea before? Or is it something new? Have I had any medical issues before? Have I been admitted to the hospital before? Have I had any surgery? Have I had any complications? Does it make sense? Past medical history. The word drug, I mean, it sounds, drug. I think that should be replaced by medication, and I think it's on its course, but still in history templates, you can see there's drug history. What medication am I on? Make sense? Yeah? Okay? Allergens. When I talk about allergies, I think it's really important to remember it's not just allergies to medication. I could have hay fever. I could have food allergies. So I want you to think of allergies in total. As a child, developmental milestones. Anything you can think of. What does this term think? Developmental milestones.
When did they walk? When did they talk?
Very good. When did they sit up? Okay, all of these things are reported by parents. Why? Because we know if there's a child and there's a delay in milestones, there might be issues. So you ask this screening question. Has your child done everything at the right age? Okay. Immunizations. Some of you in this room may or may not believe in immunizations. I respect that. And that's your own choice. And I want you to remember this as medical professionals of the future. Your decision cannot be an imposition on your patient. Okay? Be ready to have the conversation, your belief. As a pediatrician, do I believe in immunizations? The answer is yes. But can I impose it on my patient? The answer is no. Okay? Yeah. Family history. Who else lives in the house? How many other children have you got? Are you married? Are you separated? What is the occupation? We talk about it in the social history. Okay? Doctors are quite nosy people. Why, though? Is because you see the patient in totality. Okay? The next question is not relevant to children. Am I right in saying that?
No.
Very good. Okay? Teenagers, age. But what I want you to really remember is do not become the patronizing clinician. Okay? You've got to be very careful when we ask questions. What do I say usually? I say routine questions that I ask all parents. Does anybody smoke or consume alcohol? Social alcohol is absolutely fine, isn't it? It's most to do with pregnancy that we're talking about. Travel history. If I come to you with diarrhea, have I been somewhere abroad? Have I picked up an infection? So any recent travel. So once we've done this, okay, this is your clinical history as a template. It's just a brief outline and a structure on how you have a dialogue with your patient. Happy with this so far? Following this, after you've taken a history, if you visited a doctor or a GP, what do? They do a relevant examination of the patient. And this is where all these systems kick in. I've just broken down the acronyms. I'll just go through that. And my apologies to people who have a science background who are thinking I'm making it too simple. My job is to make it simple this week, because not all students will have a science background. Cardiovascular system, talking about the heart. Respiratory, talking about breathing problems. Gastrointestinal, starts from the mouth to the anus. Okay? Genitourinary, again, toileting problems, urinary problems. Central nervous system, okay, brain going along. Musculoskeletal, anything with the muscles. Any problems walking. Is it relevant to diarrhea? I've come to you with diarrhea. Should you be going through all of these things with me? The answer is yes. Okay? Because the diarrhea may be reflecting any of those symptoms. How? We'll try and see if we can find the link. And then what you do, after you examine me, after you've taken a history, you come up, every good clinician, my friends, has to come up with a differential diagnosis. If you ever come up with one diagnosis, I think you're going on the wrong track. Okay? Always have 2 or 3 possibilities of differential diagnosis, and then you come up with a management plan. Any questions so far? Okay, going forward. So, I want you to meet Nia. Okay? Nia is 22 months old, and she's come to you because she's been unwell. Nia's been brought by her parents. Okay, this is the real case. We've changed some of the names and details, but majority of the case is all real. So, she's come to you with a presently complaint. She's got diarrhea for 2 days. We met our 4 friends, okay? So, what should we be doing? How do we break down this question? Onset, duration, character, severity. Okay, so what do I need to find out about Nia's diarrhea? Is by asking those further questions. Okay? Duration, you already have a clue there that she's been having it for 2 days. The parents come in with Nia, and this is their further information. Okay? But before I go through that further information, remember this is the template that we talked about of how we break down that history. Everybody with me so far? Okay? Before we go in, okay, in terms of dehydration, I know it's a lot of words put in there on that slide, but if you look at it, it's giving you a severity scale of dehydration. Okay? So, this is all normal stuff going on here. In terms of clinical dehydration, okay, there's a water bottle here. Can I borrow your water bottle, please? Thank you so much. Okay. So if this water bottle was full, okay, that means dehydration status is normal. Okay. Now, this water bottle is less than half full. What would we call this? Dehydration. If you think of the example. But now, if this water bottle the water was still there, we would call it mild. Till there, we would call it moderate, and if it keeps going, we would call it severe. So the simple way to understand dehydration, if you think the human body as this water bottle, if anything is going in from the top and there's no leak down, that is a hydrated state. But say suppose for some reason, whatever we're putting in from the top, there's a lot of leakage in the bottom, it's going to end up in a dehydrated state. What you and me need to do is figure out why the leak is happening and what can you do to stop the leak and give the body back its hydration status. A simple concept of hydration. Thank you. How many liters of water you need to drink today? 2 liters. Well done. Very good. Is it different for men and women?
Not drastically.
So when you think about hydration states, okay, 70% of the human body is water. So if you've ever been to me, people telling you to drink water, I think after this week you will hopefully pick up those water bottles. As I speak, some of you will be tempted to pick up a water bottle. All right? Okay. Right. So let's go through some of the words. So if you were hydrated this morning, if you were in the prime of your focus and attention, you would possibly not have any of these symptoms. What we will go through with Nia as we go along is try and identify where does she fit in. Is she dehydrated? Are we picking up a state of dehydration or the word shock? Is shock a good word? No, the same medicine, okay? And we'll see where Nia falls in terms of the state. Happy? Why do we use this table is how we manage Nia. You might have picked up, I keep saying the patient's name by name. Okay? You can't call the patient it. You can't call the patient any other name. Why is name important?
Makes them human.
Thank you. Very good. See, when you use your patient's name correctly, okay? Have I called the patient the wrong name? A little bit, yes. Is it by intent? The answer is no. Because when you see 20, 30 patients on the round, you do get mixed up. But the parents, and you probably will correct me if I call your name wrong, or maybe you'll be too polite in the first meeting, but in the second meeting you tell me off. A child's name is important because it gives them a sense of connection, a sense of safety. Okay? So obviously you change the patient's name. Anybody by name Nia, the audience? Apologies. Okay, yeah. Okay, because I'm trying to come up with a name, but I'm always in corner. Last year I think I used the same name. Right. So, how do we go through the history of respiratory complaint? And for the sake of repetition, and I know probably I'm trying to get this repetition thing going, but trust me, medicine is about repetition in the first few weeks and first few years. Because you keep repeating, it's getting mastery of the skill. How many footballers in the room? Anybody who plays netball? Okay, we all need to play more sport. So, the reason I'm saying that is a second part of my job in life is I'm a football coach. Okay? I support Chelsea. Any Chelsea supporters in the room? Oh, long good. Last year we didn't have any, but this year we do. The reason about comparing with sport is you need mastery over your skill. Taking history in medicine is that mastery. It's an art. No matter what people tell you, it's science. It is always an art blended with science. So medicine without that mastery of how to approach, and you'll get that over the years. Never be in awe of somebody who's done medicine for 10 years and think, oh, how do I get there? You will get there. You just need to practice it in the 10. So, how do we go? We want to know what's happened with Nia. So the parents have told you she's been unwell for 2 days. Okay? We wanted the character. Onset, duration, character. It's like water. How do you figure it out? Is sometimes, if you go on the Swansea gambling, we'll talk about it, I think, in the future weeks. Sometimes the diarrhea can take the shape of the container. Okay? So it's really important to ask, what does it look like? And I'll show you a poo chart at some point, okay? I'll compare poo and food. Okay? Poo is, normal poo for children is like sausages. Okay, now you can get the conversation, yeah? So what do I ask them? How does it look like when you go for poo? Does it look like a sausage? They're looking at me, how weird is this doctor? Or you ask them, does your poo look like gravy? Okay, any kind of gravy, alright? Does your poo look like chicken nuggets? What am I doing there? I'm trying to make it easier for the child. I'm trying to break the jar. Okay, so it's really important to ask in simple terms. But they tell you when she goes to the pool, there are large amounts. Okay? Yeah? Large amounts versus small amounts. What is the interpretation of it? We will find out. You want to know how many nappies has she been using? 8 chance, they may be toilet trained, they may not be toilet trained. The parents are telling you it's too many for them to keep account. Good news or bad news? Yeah, it seems a bit severe, isn't it? Yeah, okay. She's sleeping a lot. A child who does not play, a child who does not push their parents' buttons at that age is bad news. Okay? If you were tired, your body would tell you, take rest. Why is she sleeping a lot? Because she doesn't have energy. The body is going into a state of rest. Why is she refusing to eat or drink? Do we eat a lot when we have diarrhea? Do we eat a lot when we're vomiting? No. Okay, so what I want to find out further is, now I'm getting into my realm of direct questions. This is what the parents have said, I've registered that, and now I'm going to go in and have more detailed questions. So I want to know whether there's any blood in the poo. Having blood in the poo is bad news. Okay? You need to figure out why. We won't go into the whole structure of why and where. This week is about learning the structure. Mucus. Mucus, in simple words, what I explain to children is like the snotty stuff coming out of the nose, like the boogies. Okay? You didn't hear the word boogies before. Kids associate it quite a bit. So mucus, white, slimy stuff in the poo. She's had some vomiting. What do I ask further about vomiting? Again, going back to our four friends. Onset, duration, character, severity. The same pros for that symptom. Does it make sense? When you practice a structure, medicine becomes easy. Let's pause there. Medicine is probably not always easy, okay? You can help yourself having that structure. When you're in a nappy, it's hard when you're having large amounts of diarrhea and you're passing urine or not. But remember, we talked about the genital urinary system earlier. This is where it's coming up from. We want to know whether she's got a temperature. We want to know whether she's got any convulsions. What is a convulsion? Somebody having a fit. You may or may not have seen a video. If you watch any medical series, there's usually somebody having a fit. She does not have any of those. Anybody else in the family who's got diarrhea? Nobody in Nia's family has got diarrhea. And this is a little bit about her past medical history. How was she before the diarrhea started? Was she well herself? She was absolutely fit and fine. The good thing about children, majority of the children, is they have healthy bodies. Okay? So it's very important to ask. You want to know a little bit about breastfeeding? And I've put this point particularly about, asking the question, whose choice is it when the baby is born? Whose choice is it whether the baby should have breast milk or water milk? Thank you. No matter who asks you the question, okay, by principle, breast milk is best. But what I don't want you to be is that patronizing clinician who makes a choice for the mother. The mother makes the choice. It is her choice. Move on. Okay? Don't get into this guilt trap of, you've got to impose your thoughts on the patients. I think that will not be received very well. But if they give you that history, you take it, all right? Okay? How many of you have got nephews and nieces? Okay. Majority of you don't. So what kids do at 22 months of age is they learn the power of no. Okay? They learn the power of no. So they reverse the tables. All these days they were this beautiful, joyous child, opening their mouth, eating their food. But they realize, hang on, if I don't eat, my parents would offer me the dessert earlier on. They would let me watch the iPad while I eat. So they turn the tables. So Nia has got a little bit of dietary restriction. She doesn't want to eat, she's drinking a lot of milk. Is too much milk good? Bad? We will find out. Okay? But that's what she's doing. And we're going through. So going through the functional inquiry, I'm just going to step it a little bit up, okay? And we go through this, but again, happy to stop and explain. I put an acronym there, okay, that you will focus on. Somebody said it's a swear word last year, and I said I'm not interested in that. So, shortness of breath, okay? Shortness of breath. Why did I put an acronym there? Because I know I'm 18, 20 minutes into my lecture, and what your mind is telling you is, oh God, there's too much being thrown at me. This is what a human brain does, okay? Our average attention spans have gone lower and lower, so I will be using some of these cues. So shortness of breath while she's feeding or she's running. She's got no cough, no wheeze. They're not able to determine properly whether she's passed urine in the last 2 days because of the diarrhea, but in the past she's had no problems. Talking about the brain, okay? Can a 22-month-old tell me if she's got a headache? Yeah. Well done. So they might not tell you, but they might be holding their head, or they might be sleeping, or they might be tired, okay? So it'd be quite hard for them to say. And again, what's the link with diarrhea? We'll try and see and find out if we're going through our functional inquiry, being a good clinician, and asking all of those questions. So once we've done this, what do we need to do? We've taken a history. We've asked all the questions. What's our next steps we talked about in our template?
Diagnosis.
We examine our patient. Very good, well done. But before we go through that, we quickly need to go through some of the elements of the history template, okay? Her past medical history. What happened to me in the past? When was she born? What happened when she was born? How heavy was she? Okay, that word there stands for resuscitation. Okay, she did not need any, and she went home the same day. She had some problems, as you see there. She was admitted to the hospital, going through the rest of these sections. She's not on any medication right now. Allergies, she's got none. Development, you go through a little bit detail, you'll see some information coming up. So all of this will be reported in the red books, okay? So there's no concerns there. She's had immunizations. She's had BCG. Though she lives in Swansea, she was in increased contact because of her father's occupation and working abroad. So they chose to have the BCG injection, which is for tuberculosis, okay? She's had all immunizations up to date. She's the only child at home. Now, the social history. Why am I talking about a detached house?
Shared entrances, shared exposures.
Yeah, good. Okay, somebody else raise their hand.
Detached houses tend to be more expensive than small mid-terrace houses, and therefore you've got, but going by the occupations of the parents, you can tell that she's at least in the Midlands or upper socioeconomic class.
Okay, yeah. Is it important? Is it important I ask the parents their occupation? Will I treat the child differently because the parents are doctors or solicitors? No. Why I'm asking this question in this context is to see if the diarrhea is a presenting feature of what we could think of an infection, or sometimes it could be malnutrition. Okay? Yep. Is it normal for kids to be carried by grandparents? Yes. Okay. Yeah. Free child minders. Yeah. Okay. Now, we come to our examination. Now, this is what I want you to remember in medicine. Okay? One of the key things about examination is not directly laying your hands on your patient. If you take a pause and you think about this, no other profession, okay, or in no other instance does somebody allow you to lay your hands on their body. So there's something profoundly very, very important to understand that about the trust the patient places on you as a doctor. Otherwise, that's assault, isn't it? If there is no consent, okay? So remember, when you examine, don't rush and jump in to put your hands on the patient and start examining. Take a step back. Observe the patient. Observe them at the bedside. Look at them, okay? But also, when you're looking at them, talk to them. Don't make them feel, why are you looking at me like this? Especially a child. If they've got a Peppa Pig shirt, how many of you know who's Peppa Pig? Oh, that's very good. For those who don't know Peppa Pig, please do watch it on YouTube tonight. So you want to observe, you want to connect to the child. You want to see, okay, if they wore a Chelsea shirt. I'm just joking, okay? They're in Swansea, so probably they're in Swansea football shirt. Why? You want to have a connection to the child. You don't want to rush in and go into a robotic way. You want to be an empathetic person with the doctor. When you look at Nia, she appears quite unwell. She's sleeping, she's tired, okay? But when you talk to her, when you wake her up, she's awake. She tells you how old she is. She's telling you to go away, don't bother me, okay? Which most kids do. Pink in air. What do I mean by that? She doesn't look pale in terms of completely pale. She did look a little bit pale. What I mean is her oxygen levels did look low. Okay, so that's what we use the word pink in air. She does have pallor, okay? I thought whether she was drinking too much milk. Pallor is anemia, okay? Yeah, low hemoglobin when you compare. I've thrown some words in. Lymphadenopathy, okay? The glands around your neck, your whole body.
How do you observe pallor?
Yeah, good question. Thank you. So in the good old day, pallor was tested with your hand to your patient's hand, assuming you had normal hemoglobin levels. But clearly, people figured out that's not good enough. Okay? A child with pallor would look pale. You would look under the eye, okay, what's the color, and they look pale. The more you look at it, you get experience to decide. But is it the best confirmatory feature? No, but at least you get a clue. So she had no swelling of the glands around the neck. Okay? The other word I put there is jaundice. You must have heard the word jaundice. The white of the eye getting yellow. Clubbing. Your hands or fingers specifically get swollen up for some medical causes. That's called clubbing. She doesn't have any gland. You check the temperature, okay? You'll see the value on the screen, which is slightly low. Now we're trying to check the hydration status. We're quickly looking at one thing right from the top to bottom. When you feel her, the peripheries, i.e. the arms or the legs, feel slightly cooler. Mom and dad gave her a drink, okay? Please don't offer a child a fizzy drink when you've got diarrhea, because it makes it worse. How? You need to figure it out. Can I also introduce you a good friend this week? The friend's name is called Y. If somebody tells you, oh, this is because of this, you need to say why. In medicine, why is your best friend. It will be heavily annoying to people when you keep asking why. Think of the toddler who keeps asking their parents, why, okay? But it's important to understand in medicine, and then it becomes easier. A heart rate. If you all record your heart rates right now, okay? Yeah, I'm not asking you to do it, but slightly. It will be there and thereabouts of 80 to 90, unless you had a lot of caffeine to keep yourself up this morning. The heart rate is going away at a faster rate. Children do have a faster heart rate, okay, for various reasons. One, because they're small, they need to work a bit harder, but probably this is telling us she's a bit dehydrated. Her heart is going at a faster rate to compensate. She's breathing at a slightly faster rate than normal. Okay, we're getting clues now in terms of observation. You check the pulse, that seems okay, and you'll be learning all these skills in your ICM sessions. Capillary refill time, I'm going to show you some videos on what this means, okay? So we're checking the perfusion, 1, 2, 3, 4, 5, take the hand off, it's coming back in 1 second. So that's not bad. And then, skin pinch. Do we really pinch children? The answer is yes. Yeah, but we don't pinch with the intent to hurt. This skin pinch is different. I'll show you what it means in a minute. Okay. And the blood pressure is normal. So you see now we're getting into the idea of we've taken a bit of history, we've examined, and we examine it further. Any questions so far? Sure. And again, I've got to make sure that I explain this correctly. Okay? For a Caucasian child, it's quite easy and visible to see if there are any issues with the oxygenation, where if they glue around their lips. Okay? And for patients with pigmented skin, what we can do is look at the gums. Okay? Because the gums are necessarily pink. But if they're going blue, that's a sign of what we call a cyanosis. After that term, introduce another word called cyanosis. Okay? Cyanosis. Make sense?
Oui.
Yeah? Okay. Any other questions?
about from the past medical history, like birth weight and all that. At what sort of age does that become less relevant?
Very good question. Thank you. Till they're about 16, I think I would do that. Okay? After 16, you will see in the adult world there's very little onus in asking those questions. Good question. Anyone else? Is it good to ask questions?
Yes.
Thank you. Okay? But I think we need to make time for those questions. Now let's look at some pictures and videos. Okay? So we use the term sunken eyes. Some of us have sunken eyes some days when we wake up. Alright? But that is probably we use it ourselves. So what we're talking about is because of the state of hydration in our body, under the eyes, the child looks sunken eyes. Okay? Showing one more picture here. So again, there. What else do you notice about this picture? This is a child we saw when we went to Gambia. Okay? What else strikes you? Underwear, yes, yeah, you can see, alright, the ribs and the state of malnourishment. Why am I showing you this picture? Diarrhea is not always infectious. Diarrhea can be because of underlying nutritional state as well. Okay? Does she look happy? Does she look irritable? Yeah, okay? So you pick up those signs. The lips are dry, okay? And again, showing you a further picture of a state. We talked about the state of shock. This is how a child in shock would look like. What are we able to see? Is she fully conscious? No. On the first day of your medical lectures, you were able to make that observation. You're very good. Well done for that. Okay? Yeah? And again, state of hydration. So that is what we would see if somebody comes with dehydration and they're in a state of shock. We talk about skin pinch, okay? The other word for this is skin tear. So what do? We expose the area of the blade, slightly pinch the skin. I've got a video to show. We take it off, 1, 2, 3. We count. So the normal count, as you see on the screen, should be, usually you will see the subtlety of the skin. And I'll show it on the video, and it will make it quite obvious. It's a good state or good way to assess the child's dehydration. In pediatrics, the onus is not on a lot of blood tests. The onus is in a lot of taking a good history and a good examination. Okay, what do you think?
That's a very dehydrated baby.
Oops. Please don't do that. Thank you. Right, so they've done the skin pinch, and the skin hasn't gone back to its state of recoil quickly. So this child, again, okay, you can argue, has got a degree of dehydration. See that further? Yeah? Compared to the previous picture again, you see the folds are higher. And hopefully this video will show us next. Okay, very gently. You're not hurting the child. Please don't pinch children. Happy with that? Able to appreciate it? And look at the child as well. Your other principles of observation. This is a child with a state of dehydration. Look at the skin and the recoil. Okay? Roughly about 3 seconds there. Happy? You appreciate the difference? The other thing I talked to you earlier was the capillary refill time. Let's see a video of that. What do you think the status of this patient is?
Shock.
Shock. Very good. Well done. Well done on recognizing that quite early. Again, you look at the hands. Okay? The hands are looking dry as well. Okay? I don't agree with the term, but medicine has got some terms like this. They're called the washerwoman fingers. Okay? But I personally do not like that term. But it's a state where the skin is dehydrated. Show you there. This is capillary refill time. 1, 2, 3, 4, 5. Take your hand off. And here it's about 1 second. So dehydrated or not dehydrated? Not dehydrated. Very good. Happy? It was about 4 or 5 seconds. Dehydrated or not dehydrated? Dehydrated. Okay, very good. Makes sense. So now, we showed this chart earlier. You're going to look at it and put it in here. Did she appear very well? The answer was yes. Okay, she was a bit irritable, and she had these yellow ticks. She did not have any of these, okay, but she did have two of these, tachycardia and tachypnea, as we call it. Wherever you see the word tachy, okay, not in the word T-A-C-K-Y, but T, okay, tachycardia, an increase, bradycardia, a decrease, dyspnea, wherever you see the word D-Y-S, that means pain, okay, dysarthria, dyspnea, you hear a lot of these terms. It is not a bad idea to open the medical dictionary in the first few weeks. If you don't understand the term, or maybe you can just Google it these days, okay? We started our first year with the medical dictionary. I think you have it available online. Happy what we've done so far? So what do we need to do with Nia next? We've taken a history, we've done an examination, we think she's dehydrated. What are we going to do next? We are going to manage Nia. Okay, what comes to my management? What do I do with Nia? How do I help her? And before you do that, you quickly want to run off and look at the other systems as well, okay? What we call is the systems review, and your ICU session will go through this further. But very quickly, again, we talked about the jargon that I've added there. We talked about heart rate, okay, how fast the heart rate is going. But sinus rhythm, what does that mean? Sinus rhythm simply means when the electric circuit of your heart is starting, it's starting at the right point and ending at the same point. So it's all happening in a nice way. That's what we call the sinus rhythm. Apex beat. If you put your hands on your ribs or the fourth intercostal space, which again ICM will teach you, you feel the apex beat. So that was normal with her. Her heart sounds, they're normal, okay? This is just to give you an idea of what people will record in the medical notes. I talked about the term earlier, dyspnea. She does not have any difficulty in breathing. Okay? We check the windpipe is centered. It's in the right position. The breathing is fine. Percussion, where you percuss, okay, on the chest. And I want to talk a little bit about the art of percussion, but I know the time is short, so I'll move on. We'll come back to that the next time you see me. So the breath sounds sound quite musical as well. Okay, so there's no problems there. Again, going through, quickly examining, this is to show you again the structure. Everything seems normal so far, okay? No issues. Again, any other system that I haven't mentioned so far in terms of the examination? Again, thinking about the head, okay? That was the last one. And then what was good was everything was normal. So this is good news for you? Yeah? Okay, examination being normal is good news. So to summarize, Nia, what we've got so far is she's come to you with diarrhea. She's going on for 2 days. She's been previously fit and well. She's got no other problems. We worked out that she's dehydrated. We thought she had a little bit of anemia. What do I think next after the summary? What should I do in terms of a diagnosis? What do we call that term? We call it differential diagnosis. If you come up with one diagnosis, you're going down the wrong route. You always need to do a few differential diagnoses and then narrow it down further. So, these are the differential diagnosis and the working diagnosis. So the first thing we talk about as a child who's in Swansea, okay, it's really important with no travel history. She's probably got a viral infection that's caused a little bit of diarrhea, a little bit of vomiting, and she's dehydrated because she's not drinking enough. Okay? Comorbidity. What else did we find with her present complaint? We thought she was slightly pale. In medical terms, we call it anemia. What else could it be in terms of a differential diagnosis? Could this be a bacterial infection? She does not have a temperature. Or does she have a temperature as we go along? So that's the way you're looking at it. She does not have any blood in her poo. But still, it could be possible that this could be bacterial. Okay? She's got a bit of vomiting.
Is that the reason that viral is the working diagnosis and bacterial is the alternative differential because of the lack of temperature?
Very good. Lack of temperature, lack of blood, okay, no foreign travel, no contaminated meat. That's exactly the kind of thing you know what to think.
But did the anemia not make it lean more towards bacterial than potential
think that could be because she's drinking a lot of milk. She's not eating a lot of solid food. So you see how the past medical history is really important? Yeah? But that's the kind of thinking I want you to do. Well done. I thrown in a word called obstruction. She's vomiting. Anything that's obstructing the food from going to where it should. Okay? And I put in the word intussusception. That's again a medical term for a kind of intestinal obstruction. As your colleague rightly pointed out, you need to think about why is she anemic. We've got some clues. She's drinking a lot of milk. Okay? Children do not eat a lot of red meat. Now,
Sorry, can you go through the difference of working diagnosis and differential diagnosis?
sure. So the working diagnosis is what I think of immediately from what I have in front of me in terms of a history, in terms of an examination. I don't have any blood tests yet. I can only use my powers of reasoning and then come up with what is the most common one in this part of the world. That's what I think is a working diagnosis. The differential diagnosis is what I think, what else could it be? Am I putting all my eggs in one basket or can I think of other possibilities? A good clinician will always do both. A cocky, overconfident clinician, you will come across them. Alright, get ready for that. Okay, there's no harm in not talking about it. We'll probably stay in one track. This is what I think, this is what we should do, go on. Okay, you don't want to be those clinicians. Okay. Happy? Does it answer your question?
Thank you.
Lovely. So, management plan. What do I do for Nia? So now, a simple analogy of the water bottle. Okay, Nia is having a lot of diarrhea. So what should I be doing from the top? I should try and fill the tank up. Okay, what are the routes for filling it? I can ask her to drink, but she's not really there to drink. I.e., in terms of she's not willing, she doesn't have the energy. So I can think of two other routes. I can put a tube through her nose into her belly, okay, where I can give her the water, or I can put in an IV line and give her IV fluids. Make sense? Why? Till these losses that are happening, I want to gain, fill up the tank. It's a simple concept. You're filling the tank, and the tank is getting empty. Happy? What we did not talk about is what's happening inside the tank. You'll have to wait for that for Wednesday. Yeah. Right, so what do? I assess the dehydration, I plan for it, and I correct the dehydration. If I'm putting the IV line, I probably want to do some blood tests. The full blood count will give me an idea about her anemia. If you're losing water, you're losing salt, you're losing potassium. So I want to check what we call as the electrolytes. Make sense? Yeah. And we didn't ask for any other fancy blood tests. That's a slight nuance about pediatrics where you don't do a lot of blood tests. And then, is it good? We just leave her, or common sense will tell us we need to monitor her. Okay, that's where our nursing colleagues come in and keep monitoring the child. You would go in, keep monitoring the child. What would I do when I'm monitoring the child? What should I be looking for? I probably would be checking the heart rate. I'd be checking the perfusion. I'd be checking the skin turgor. Is it getting better or is it getting worse? If it's getting worse, she probably goes into a state of shock. If it's getting better, I know she's getting on the road to recovery. Make sense? What else haven't I done so far? Which I should be mentioning, I should be speaking to parents. A clinician who cannot communicate, you can have a PhD in dehydration, but if you cannot communicate to your patients, I'm afraid that's not good enough. Okay? No matter what you do, at the heart of what you're going to be as a clinician is you're going to communicate. Okay? Tell the patient what is happening. Don't let them imagine what's happening. Okay? Try your best to communicate. So, I told you the word, oral rehydration fluid. How many of you had diarrhea? That wonderfully tasting fluid, which is absolutely brilliant to drink. You all tasted it? Blackcurrant, orange flavors, but still not the best drink of that. Okay. One of the secrets I learned about, how did I first learn about oral rehydration fluid? First year's freshest party, nice food, my teacher told me the next day, to get over my headache, I should drink diarrhea. Okay, so if you're having a freshest party, you may want to drink some diarrhea. Okay, that might help you.
Before you get
right,
to that.
okay. Before I show you further slides for getting access any further information, I know it's 60 minutes and I need to let you go now. Thank you for staying for 60 minutes. None of you left, which is a good sign. Okay? Are you going to go?
That is
Any
our first
clarity
lecture.
or any point you want to ask me?
Talked about the power of no. Was she only drinking the milk because of the diarrhea, or is that earlier on? Was she not eating and just having milk and just going like that?
Yeah, that was before the diarrhea kicked in. She was only keen to drink the milk, which majority of the children want to do because eating food takes them away from fun activities. Yeah. The sign that we picked up on the other guidance and gender appearance. Not scientific, but gives you some clues. Please stay with the questions, folks. Some really important questions being asked. Normal would be 2 or less than 2 seconds. Okay? Any other questions?
Did she present with any abdominal pain or bloating or anything?
Good point. She did not. But when you see again for a 2-year-old child, probably it's hard for her to say my tummy is sore, but that's for us to discern. But it did come across that she was in tummy pain.
So
Very good point.
what would be the biggest difference between bacterial and viral enteritis?
Good point. And again, we'll pick this up on Wednesday to see the pathogenic mechanisms. But you see, bacterial diarrhea, your patient would be more toxic. There'd be more features of shock, more temperatures, looking signs of sepsis, okay, blood in the poo, all those things are history.
Is it generally less common? Like, would that normally happen due to like traveling or consuming something that
Excellent
is?
point. Yes, in this part of the world, less common to have bacterial diarrhea. Yeah, but again, in the developing world context, it is a good point. Good questions, folks. You need to keep thinking about this.
What kind of features would you find in this patient on an after exam?
What?
Features on an after exam?
It was normal examination essentially. She did not have any pain when we were pressing her belly. So it's, in a sense, it was a normal examination. Yeah, I like the thinking, and probably on the right track. Other things kids do is they play a lot, they put their hands in their mouth, which are probably not clean, and they go to nurseries. So they pick up bugs there as well. Again, good thinking. Right, so finally, if you have some time this week, you'll be shown a lot of material, okay? That's all right if you can't cover off it, but there's a lot of information available on that website, and I want you to be Sherlock Holmes. There's something wrong with here. I want you to figure it out, okay? Where are the pills? The pills are probably in a handout on campus.